We're on. Film at 11. My name is Dr. Eric Smith. I'm the Medical Director of Whatcom Occupational Health. And I am board certified in occupational medicine. And occupational medicine is this wonderful little rutted side road off the highway of medicine. But I love it. I've been doing it for, 30 plus years. I wouldn't say longer, but anyway, and I'm residency trained in occupational medicine, and there's not that many of us doing this kind of work. And I'm clinically oriented. Occupational medicine is part of public health, as opposed to many of my colleagues in public health who love the public, just can't stand people. I actually see clinical occupational medicine problems, and it's a fascinating field, and it's varied and interesting, and we get boo-boo owies to people with devastating injuries that preclude them from ever returning to any work. And so you've got the spectrum of disease. Now, today we're going to be talking about repetitive motion injuries, which is an occupational disease, although some of them can be considered acute injury, and we'll get a little into that as we go along. So I'm going to make sure my machine works. Okay, where are you? Oh, please don't do this to me. I hate this.
If you hit the space bar, I think it might...
That space bar, this one?
Yeah.
Miracle. Thank you, Dave. Save me again. All right, so repetitive stress, cumulative trauma. Basically, it's not an acute injury. Some similar things that cross over. You can get a traumatic event like a direct blow to your elbow that can kick off a condition called lateral epicondylitis, which is often referred to as tennis elbow. Although after 3,000 cases I've seen over my many years of practice, I've only seen one case that actually occurred from tennis. But that can be a direct traumatic injury, and so that's an injury, but most of the time it's from repetitive hand activity creating the problem. So it's usually, if you're doing something on a repetitive basis. For example, as an MA, if all you did all day long, like 10 times an hour, is check somebody's blood pressure. Now, I would submit to you that's probably unlikely to occur, but if you were sort of in an assembly line, you know, getting ready to get to the blood pressure before the blood draw or something like that, and all you're doing is pumping up the insufflation of the blood pressure cuff, you may develop a problem with your arm because of the repetitive nature of your work activity. So there are some times where, you know, in the medical field that can occur. I once treated a dentist who had raging flexor tendinopathy with irritation of his median nerve. It's like acute carpal tunnel. But the day before, he did 3 root canals, which is highly repetitive. And, you know, I said, dude, you know, you can't do that many, you know, bang, bang, bang. You know, it may be a good moneymaker for him, but you pay for it. And I can't imagine anyone, you know, looking into a very dark, moist hole and doing work. To me, that sounds, I admire dentists who can do that, but not me. So, neuropathies, which is irritation to a nerve, carpal tunnel syndrome, which is the median nerve right here, but there's also radial tunnel syndrome. There's ulnar nerve from the funny bone, which all have, and then there's also another ulnar nerve entrapment, can be a Guyton's canal in your hand. And we'll talk some more about that as we go along. So, look at that cost, and that's probably underestimating actual cost, because, you know, it is a lot of money, but there are a lot of people that don't see it as, they just think that they don't realize that the repetitive nature of their activity may be contributing to it. And employers have a tendency to be dismissive of cumulative trauma disorders, and state laws are different as causality. Washington State does accept carpal tunnel if there is a unique job characteristic that led to the CTS. But you go to Texas, you go to some of the places in the South, nope, no how, no way is carpal tunnel ever work-related. They have a, shall we say, a dogmatic and draconian concept about cumulative trauma disorders. And people may complain about the state of Washington in a lot of respects. I mean, it is pretty wet and windy at times, especially in November. But the workers' compensation system actually, I think, is one of the best in the United States, if not the best, because how they've looked at the causes of various occupational diseases, such as cumulative trauma. So, oh, I keep pressing the wrong button. Okay. So the unique anatomy of the worker and the specific stress placed on the worker by the job task may dictate where the cumulative trauma occurs. So there's a 3-to-1 ratio of women to men. And if you look at your neighbor next to you, you notice that people's wrist sizes are different. And the smaller, the squarer your wrist, the more likely you are to get carpal tunnel. Because in men and women, the median nerve is about the same size, but our wrists are quite different. And flat, broad wrists this way, rectangular wrists, are less likely to develop carpal tunnel. And of course, women have hormonal issues, they fluid retention, and they often have to do a lot of repetitive hand activity, not only at the workplace, but when they get home, because hubby may not be contributing his fair share to some of the tasks that need to occur. Not that that would ever surprise any of you. Okay. So in shoulder, the supraspinatus tendon, which is out here, bicipital tendon, the glenohumeral joint, the acromioclavicular joint right here, lateral, which is here, medial, which is here, epicondylitis, first compartment, which is down here, the extensor hallucis longus and brevis, which is, anybody heard of de Quervain stenosynoviitis? Well, there you go. De Quervain, gosh, go figure, he was French, but in the late 19th century wrote a paper about the development of inflammation to the tendons. You know, this is our anatomic snuff box, and you have the tendon, the brevis longus to the thumb, and repetitive hand activity like that can develop a problem. It's a frequently caused thing. We call it, in our field, the green hand syndrome. Why do you call it the green hand syndrome, Dr. Smith? Well, they're green to the work activity. They're not used to it. They haven't gotten in shape and conditioned for it. So they do a repetitive hand activity. I see it frequently at these just-in-time labor pools, the ready labor, temp agencies. They send them out to some food processing place, and they put them at the worst job in the plant because they really need a lot of work done, and they're there for 12 hours. They're happy to have a job, and they come in like 2, 3, 4 weeks after they started. They're just can hardly move their hands, and it's all inflamed. And then I have them, I put my hand right there and I have them move their thumb, or I move it for them, and you can feel, it's a palpable creak. We call it crepitance, which is basically, it's you can feel it. And sometimes it's so bad you can hear it. It's so inflamed. And what we have to do is immobilize their thumb and their hand, and sometimes we have to do cortisone shots. Yes, ma'am?
Does that have anything to do with it? And again, a lot of those instances in the food processing situation, it's cold and it's wet.
Well, they're mostly well dressed for that, but you know it is an unpleasant environment. But it has to do morally with the repetitive nature of the movement required, and a lot of those food processing plants. I've seen some rip-roaring cases de Quervain stenosynoviitis because they don't sharpen the knives, and they have to use more force to cut. And they don't want to have the knives too sharp because people get cut with laceration, but then they develop an overuse problem. So it's like, what are you thinking, you know? And they should have, you know, knives that make it easy to cut. You know that when that first time you get that new knife out and you slice that tomato and you go, wow. And then 3 months later, it doesn't work as well because you didn't sharpen it. You don't use the sharpening machine. And that's what frequently happens. And these people are cutting all the time. A lot of restaurants now, they don't own the knives. They contract with an outfit that sharpens the knives, and they get new knives every 2 weeks. You know, they just turn them over so they get sharp knives. Okay, and the vascular system. There is a thing called, and we'll talk about it, where they actually pound away and they can develop a trauma to the vascular supply of the hand because of repetitive, inappropriate hand activity. All right, shoulder impingement syndrome, which is very common, okay? We refer to the painful arc. I'm sorry, this poor guy is trying to go up behind me and walk around, my hands are going, and I apologize. But the painful arc is 80 degrees, 120 degrees, 45 degrees back, 45 degrees forward. That is where you keep your elbow in there. You're more likely to catch the supraspinatus tendon, which is out here on the end, on the acromion. Now the acromion, the genetics has something to do with it. We're talking about small wrist size. But there are 4 types of acromions. One goes up a little like that, another was a little flatter, goes down, and then one's curved like that, it's type 3. And there's a type 4, which looks like you just dig it into that tendon, it goes down like that. And people have no control over how that acromion looks. It's just only undiscovered, and it says, oh, well, there you go, there's your problem. You have a grade 4 acromion, so you're kind of set up for problems. But the most important thing, what I often teach people to avoid problems with their shoulder, keep your elbows in. You have to lift, you keep your elbows in like that, right along your chest wall, like that. You're less likely to have the impingement. And impingement refers to catching the tendon on the acromion. So that's why the supraspinatus impingement syndrome. Stand up for me, Dave. I want to show you there's a little typical examination. So this is what I've got a shoulder. What we do is that it's a can of pop test. So I have him turn his hand like that, go up against my resistance, and he says there's pain right there. That is a positive impingement sign because I'm isolating the supraspinatus tendon, and he's going into that painful arc, and then he complains of pain right there. And that's a pretty typical. I don't even need an x-ray. You know, if the anatomy and the range of motion is okay, why get an x-ray? Because it's a soft tissue injury. Now, we can get an x-ray, we may have to, but actually it's better diagnostic testing if it doesn't get better. And we often do the corticosteroid injection if it doesn't get better. An MRI arthrogram, because that tells us if there's a rotator cuff, you've got tendinopathy, you've got bursitis, a number of other things going on. So we're talking about the acromion type here, and more likely on the dominant side, but if someone has a unique job and they have to reach over here to get the product, then they do something with it, but they're reaching out there with their non-dominant side, you can develop, of course, on that side. It has to do with the amount of activity they're doing. Okay, now this is very facile and glib of me to say this. Okay, but you know, we are part of public health. We don't want things to occur. Now, years ago, it's sort of like apocryphal story. There was a doctor in eastern Washington who was near a food processing facility, and he was the closest doctor to and he was getting eye injury after eye injury after eye injury. So he said, aha. So instead of talking to the company and saying, you need to have an eye protection program, everyone should have safety glasses, and all that logical stuff, he went out and bought himself a slit lamp, because then he could better take care of all the injuries. So this is kind of what, you know, maybe you ought to help people so they don't have to come in and see you. But that would be, so there's a lot of things I do. I give away a lot of information to people because it's the right thing to do. And I am part of public health, and I'm trying to help people avoid injuries. And I actually had some today. I was talking to somebody and they wanted to come in and do something, and I said, well, okay, we get this going. are you willing to get treatment for it, an active curative treatment? And I said, well, not really. Then why are we doing this? So she just wanted, for some reason, someone told her to come in and see me. All right. So workstation that minimizes reaching or overhead. There is a good area in your body. So we talked about keeping your arms into your side, but above your knees and below your shoulders, this is where you should be doing everything. So there are some people that are, shall we say, vertically challenged, and they need to step up, you know, like a couple inches so they can get up there. One of the worst things one of the worst things I ever saw locally was a food processing facility, and they had this little gal, and she had to lift a 40-pound bag of sugar over her head to dump it in the hopper. And I asked them, why didn't she have a step up? Oh, well, we don't want to have, you know, too many, she might trip on it. Really? You know, I can't tell them how to run their plant, but I can say, you know, that's probably not a great idea. You know, and there's some people that are really tall, and I says, well, where's the portable hole for this guy? You know, the joke. Okay. All right, so you know what you want to do is find something where there's adjustability. And if you have to lift from the floor up, why don't you have a scissor lift? Because there are some things, or, you know, have something where you can adjust it and they can just pump it up. You know, it's like a lot of people, you know, where they have adjustable tables. Turns out they're starting to get tables for all those kids because they're all hyperactive and ready to go, and you know, having them standing at a table is actually better than sitting, and they actually can you know, process the lessons better. It's finding the right scenario for the workstation, what people would do well at. So so green chain, drywall hanging, roofing, framing, you can't change those. They're just awkward. And that's why, you know, what I often see, you know, someone comes in and one of the reasons, why do they go into all this heavy demanding work? Well, you talk to them, they hated high school. They barely got their GED or didn't. They went out in the workplace and they're working right away. And, you know, this is the adult attention deficit disorder. You know what that is. They say I have ADHD. Oh, look, a squirrel. So this is very common what they do, and trying to get them to, you know, kind of address some of their issues before it gets too bad. But I tell people, you look around your job site. Who's the oldest guy on the job group? They say, well, me. There's a little lesson for you right there. You know, there are some jobs that are really much better for somebody physically younger, and because they do it. The dirty little secret about getting, I don't want to say older, but I've seen too many calendars. In fact, I'm not old, I'm chronologically gifted. But after the age of 30, we lose 8 to 10% of our total body strength for a decade. And I used to be able to have 2 40-pound bags of mulch under my arm, and now I lift one and it says, how the hell they get so heavy? So, you know, really, it's really important for you to understand that this is just a natural process. We all are subject to the second law of thermodynamics, which is the law of physics. We go from state of order to disorder, and that's just the way it is. We call it aging. So trying to work smarter and not put the physical stress on it. If you start getting a tinge of discomfort while you're doing something, you got to look at why you're doing it that way. You know, there's some jobs you can't modify, you can't change, but you can break up the activity. There's no reason why you have to collate, you know, 25 different handouts. Break it up, Dave. Anyway, so.
By the way, I've got a claim I'm bringing in.
Yeah. Well, good luck on that one. Has to be on a more problem-on basis. I don't think so. Anyway, alternating your work activities. Keep your elbows next to your chest. There are some recreational sports, you know, baseball pitchers, of course, softball. I have a rule of thumb. Now, you know, everyone says, well, you put the ice on it for, you know, 24 or 40 hours, then you go to heat. Oh, no. Rule of thumb, if it hurts, use ice. If it's stiff or started tight, use heat. But you don't, there's no hard and fast rule about it. I've seen people that needed ice down their back because they had such severe spasm for a week and a half. So it doesn't necessarily follow you to do that. And I've seen some doozies. The guys are always the ones that do it. You know, the guy comes in, he's got a perfectly square red mark on his back and says, well, what was good with the heating pad, so I turned it up and I fell asleep. And he had a first-degree burn on his back. Then a couple years later, I had a guy come in and he's got this big blister on his back. Oh, he fell asleep on one of those chemical ice packs and he's got frostbite on his back. So yeah, it's always guys. It's always guys. You know. Anyway, but if you're really, you know, things are bothering you, need to go seek medical attention. So, you know, history. If I have somebody who says, well, it wasn't bothering me too bad, and then it slowly got worse. And then I asked them, so when you went away for a vacation, or you had a 3-day weekend, or something, did it seem to get better? Oh yeah. Yeah, and then I went back to work, and you know, by Wednesday, it's just killing me. You know, that you've got this nice temporal association between the subjective symptomatology and the development of his problem. That is clearly what we listen for as far as an occupational disease claim for musculoskeletal cumulative trauma disorders. All right, so X-ray is really not all that useful because if it's a cumulative trauma, there's not direct trauma to it. There's no, you know, you break something, you have immediate pain because it hurts. With this, it's sort of like a kind of smoldering kind of thing. You know, sometimes you find with a shoulder, you get an X-ray and you find calcium deposits or something that shows up, but it's rare. You don't necessarily, remember, X-rays are ionizing radiation. I mean, did you know that one CT scan is the equivalent of 300 to 500 chest X-rays? We don't necessarily need to get more of those. There's a whole cohort of young people that were given, you know, when CTs became really popular, we're doing a lot of them. That's a lot of ionizing radiation. So I would really want to think about, do I want to order an X-ray? And unfortunately, the studies have shown if a doctor's office has X-ray in the doctor's office, there's more X-rays ordered, which is disturbing because, you know, you think about that, that's obviously, there is, you know, maybe a dead president or two that are interested in meeting. Yes, ma'am.
With Washington State Department of Labor and Industry, that has been a contention for quite some time with a number of physicians, is that quite often they say, must have an X-ray to rule out or to confirm this diagnosis.
Not necessarily. What you can do is you say that the reason I didn't get the X-ray is because of soft tissue and X-rays would not show that. They have to clarify. Part of the problem is electronic medical records. Oh my God, it's just like garbage in, garbage out. We don't do it at our clinic. We dictate it. People, we use a SOPR form, subjective, objective, assessment, plan, and then R for return to work. Oh my God. It's kind of hard to see it. All right. So, steroid injection. This is for shoulders, so we're going to go on to the next. Okay. Modify work activities. Go figure. Now, the best places that, you know, really have a sharp safety coordinator or human resources will try and figure out alternative work activities where they rotate into different work areas. You know, it's, if you write out, there's a thing called an activity prescription form, which is sort of like where everyone's gone to with the Department of Industries, and you write out, you know, modified, you know, limited bending, scooping, lifting, and they go back and their employer is kind of a knucklehead and says, well, just do your regular job, just do it slower. Well, if your job's lifting 50-pound bags of dog food, that's really not a modification. So it's important that, and you know, one of the things I've learned over the years is if you're going to do occupational medicine, which I do, you got to give good phone. And talking to the various stakeholders, once an individual signs a physician's initial report, that allows you to speak directly to the employer of record, human resources, or safety coordinator, or their immediate supervisor. There's no patient-physician confidentiality. and the providers can bill for it. It's a 99441, but that's neither here nor there. Anyway, so you can't keep doing, so this is for shoulders, you don't keep, I do one injection, not better, it comes back, they're really hurting, they have decreased range of motion. MRI arthrogram is where you need to go. That's actually the better thing. So let's talk about lateral epicondylitis tennis elbow. 3% incident rate is probably one of the most common cumulative trauma disorders that you'll see. It has to do with your reaching for it. You can get it for just reaching for a coffee cup, and once it gets started, it has a life of its own. It keeps going on. What it is that people say it's a tendinopathy, it's not really. It's the muscle attachment at the lateral epicondylar structure right here. And that tissue sometimes frays and becomes uncomfortable. Now I'm going to show you a little diagnostic test. Dave, stand up again. You're here, you're there. So this is a really good test. If I go like this, and I point right there, and it's right over his lateral epicondylar, he doesn't like it. But here's a provocative test. There's actually an eponym for it. I don't know what I keep forgetting it. Push your middle finger up against my resistance. And you do that, and it hurts there. That's clear-cut evidence of lateral epicondylitis. So it's a provocative test, and I looked it up. There's some guy's name attached to it, but not the whole hand, just the middle finger, because the attachment of the middle finger is the furthest back or proximal of the elbow. Okay, medial epicondylitis often is traumatic. They bang down like that, but you can get it down here, and it is a little more difficult to treat. Now, lateral epicondylitis, the best thing you can do is a tennis elbow strap. There's like 25 or 30 brands on the market, and there's all sorts of good ones, bad ones, and different ones. But the most important thing, again, stand up for me, Dave. So, anyway, I usually use 2.5 finger breadths for the upper one. It's basically a mechanical advantage. And this is how you test to see if it's going to work. Okay, so you go up like that, it hurts. Okay? You say, ow, there you go. So if I put my thumb right where I want it to go, and you go up, and it says, it doesn't hurt as much. It's giving a mechanical advantage. Instead of the stress being here, it's the stress is down here. That's how tennis elbow straps work. Okay, I've seen people with tennis elbow straps down here, I've seen them all the way up here. They're putting it in the wrong spot. And so it's really important that if you're going to use it, put it where it's supposed to be. Okay, so there we go, the interdistal prominence of the humerus. Okay. Now, sometimes people say, it really hurts right here, but actually they're referring to is the ulnar nerve, which is right in the ulnar groove right there, which is different. And that can give you another problem altogether. All right, forceful pinching, gripping, hammering, shoveling, pulling wire, trimming, anything that's repetitive. It's usually the dominant side. Again, micro tears the muscle attachment of the bone with secondary inflammation and pain. Now, I talked about green hand syndrome, and this is in your handout. So they just start developing problems, and they get it lateral epicondylitis, medial epicondylitis, the Quervain's tenosynovitis, acute flexor tendinopathy. There's all sorts of problems they can have wherever the stress is, and wherever the weak spot in their hand or arm is, that's where the inflammation can be, and that's where they can have pain. Yes, sir.
Just a question. I had what they call trigger finger, and I had it in both hands. And they said I got it because I was gripping repetitively.
On a motorcycle?
No, it wasn't a motorcycle. It was a pneumatic tool that I had to hold and I had to grip tightly.
Yeah.
And
well, that is a problem. What happens is there's a little nodularity that develops over the flexor tendon, and then there's this little pulley systems, and they get caught in the pulley. So you notice first thing in the morning you couldn't open your hand, and then after a while you got up because the swelling went down, and so then it would work, and then finally it just freezes in place. But you don't want to wait that long. The solution is a corticosteroid injection where the pulley is, and that usually does it. But sometimes they have to go in there and open the pulley.
that's what they did, is they cut the sheaths that was surrounding the tendons.
Yeah, and it's very common and it does occur. There's a predisposition towards that, but, you know, it can be work-related. Yes, ma'am?
Is the predisposition partially male?
No, I've seen it, yeah, I don't know, there's, you know, I've seen it both. It doesn't necessarily follow. There are some of the problems that do clearly, you know, favor one or the other. It depends on the typical, you know, guys, there's this thing called hypothenar hammer syndrome. And I've only seen it in guys because they're usually, you know, they don't want to wait for the hammer and they just start using their
You've got it.
hypothenar and they're banging into something and it causes a problem and they end up with ulnar problems, guidance canal. They also may do some damage to the arterial supply to the hand. All right, no rotation, poor tool design. One of the things that the dentists have really kind of finally caught up to, if you notice, you go in the dentist's office, they used to have these long, skinny metal tools. They go in there, and now they've got these big fat handles on them because they're much easier to grip, and so they don't end up forcefully gripping. And I don't know if you've seen some of the butcher shops, some of the places have L-shaped knives with the handles like this, because this is a more neutral hand position, and they cut like this. It's much easier to chop something with your hand like this than try and do that, unless you know. So those are the kind of things that ergonomic tool design has really improved things. All right.